Hi, hi, Dr. Vasiliki. How are you?
Hello, Jason. Hi,
Hi.
how are you? And
Uh,
welcome to everyone.
yeah,
Are
first,
we ready?
yeah, we can still wait 2 minutes for the
Yes, we will
participant.
definitely wait.
Yeah,
How is everything in
yeah,
China?
yeah, because we are doing the Chinese New Year. So,
Yes, Happy New Year.
yeah, I want to say Happy Chinese New Year to all the,
Happy Chinese New
yeah,
Year. Yes, to
yeah,
everyone.
everyone.
Okay, let's wait for a second so that other people can join as well.
Yes. Okay, I will give you the host.
Yeah, so that I can share screen.
Yeah, okay,
Okay, let's get back in a couple of minutes. Okay.
yeah. And again, I want to say hello, everyone. Welcome to Aohua Vet's webinar. I'm the host from Aohua. I'm Jason. Some of you may curious about Aohua endoscopy. Actually, we was established in 1994. So now we are 30 years old, and we focus on endoscopy solution for both medical and vets during the 30 years. And for this year, we also have monthly webinars on Zoom and also the clinical cases on YouTube and other social media. We want to bring all the veterinary endoscope users together and to share their knowledges and experiences. So after we start, please feel free to ask any questions. You can put them in the Q&A box. Okay, let's wait for the Dr. Vasiliki. Yeah, I
Are
think,
we ready? Can we
yeah,
start?
yeah, I think
Definitely.
it's time. Okay.
Okay, it's going to be part two of gastric hypomotility disorders and outflow obstruction. And this was what we have talked about last time. We have shown there are two main categories of hypomotility disorders. The first one are due to mechanical obstruction, and the second one are due to functional hypomotility, functional obstruction, as we call it, which is not a true obstruction, to be honest, but it's gastric stasis and it's generalized as GI dysmotility. So, in terms of mechanical obstruction, just a quick reminder, we could have the complex of diseases of hypertrophic pyloropathy and hypertrophic gastritis, which could be located only in the pyloric and in the antral region, or it could be a more diffuse disease. It could be due to neoplastic disorders that are actually obstructing mechanically the pylorus and they don't let the gastric outlet to be free. Due to foreign bodies in the pyloric region again, or even in the intestinal, in the small intestine, the proximal small intestine, and also sometimes due to external decompression of the pyloric region from enlarged abdominal organs, such as the pancreas, the liver, some masses in the duodenum, maybe, or in the region, even in the pyloric region, and also the duodenogastric intussusception. Um, and in terms of functional obstruction, we could have primary GI disease, like the infiltrative diseases, all kinds of IBD, severe IBD cases that could cause dysmotility, pancreatitis, secondary diseases that actually reflect due to electrolyte disturbances could cause dysmotility disorders. some drugs, some medications like cholinergic antagonists, and it is very, very common, and please write in the chat box your experience in that. A lot of dogs that have undergone gastropexy due to gastric dilation and volvulus, they, in their recovery period, they experience dysmotility, hypomotility, gastric hypomotility. This is not, sometimes this is not responsive to medication. The other thing is that we could have also endocrine diseases that could cause neuromuscular diseases that could cause hypomotility, generalized hypomotility, like hypothyroidism, and we will talk about a case. Addison's disease, mostly in the esophageal area, causes mostly esophageal and not gastric dysmotility. But there are endocrine diseases that could cause hypomotility disorders. Okay, so last time we discussed two cases. One was due to, it was an obstruction due to a foreign body in the pyloric region, which is very, very common. The second case was a pyloric stricture due to severe fibrosis from an animal that has consumed non-steroidals, human non-steroidals drugs. And today we're going to talk mostly about functional obstruction, like obstruction due to eosinophilic IBD, prolonged in many cases, prolonged vomiting, prolonged duration of long vomiting periods could cause fibrosis in the pyloric region. And this could secondary cause obstruction, but it's not only that. It's not only the fibrotic component. It's also that the infiltrative diseases can also cause dysmotility by the infiltration per se. So a second case would be about lymphoplasmacytic IBD, maybe on grounds of food allergy, presumptive food allergy. We're going to have the bilious syndrome. We're going to discuss the bilious syndrome. We're going to discuss the newer prokinetics, the treatment, which I didn't discuss in the previous webinar, and we're going to discuss also the diagnosis of gastric hypomotility. So let's go in this Rottweiler. You can see how much, how depressed this dog is. He's looking downwards, and you see that that this dog has hypersalivation. It's drooling. The whole sheet is full of saliva. Okay, and he has this, he does a bit of ptealism, and he has foam in his lips, in his downward lips. And as you saw now, it regurgitated, maybe not that, it didn't expel the food in the sheet, but it had something like the gastroesophageal reflex. So this dog was referred to us with chronic vomiting and chronic mixed intestinal diarrhea when he was 1.5 years old, with clusters of vomiting, 5 to 6 per year. And the duration of each episode was a bit prolonged. It could last from 1 day to 1 week, with partially digested food. Gastric fluids, it was not consistent. Other times it was partially digested food, other times it was gastric fluids, and the frequency was 1 to 2 times per day, as you see. So we had weight loss, anorexia, and depression. And there was a temporary response to common antiemetic treatment that the referring vet would use, like meropetant and cimetidine and omeprazole and metoclopramide. All these measures, all these therapeutic regimes would work for a while, but not for long, because we had recurrent episodes. This dog had been on hypoallergenic hydrolyzed diet, on GI diets of different brands. Once they stopped the medication, the symptoms recurred. And he also exhibited pica. So he would eat practically anything, like from stones to grass to licking the surfaces of the floors, actually exhibiting maldigestion, discomfort, abdominal discomfort. So this was how he was placing his head on the couches because he was feeling really, really nausea. And this is another sign of abdominal pain, how dogs exhibit abdominal pain. It's not just the prayer position. It's also this position that they feel discomfort into lying down. Okay, so back then, 4 years ago or 2 years ago, the upper GI endoscopy gave us a diagnosis of moderate eosinophilic gastritis with ulcerations. You're going to see the gastroscopy that we had from this dog. Eosinophilic granuloma formation in the stomach, in the fundus of the stomach and in the antral region, and focal fibrosis. So the diagnosis back then was mild eosinophilic enteritis and moderate eosinophilic gastritis. And because it is a Rottweiler and we're really, really afraid and cautious about hypereosinophilic syndrome in Rottweilers, we should check once we see an infiltration of the small intestine and of the stomach with the eosinophils, then we definitely have to check the liver. We definitely have to check the bone marrow. And the fact that this dog had pronounced peripheral eosinophilia, almost 9,000 eosinophils in their circulation, in the peripheral circulation, this raised a high suspicion of hypereosinophilic syndrome. You see that at that time we had leukocytosis with 35 white blood cells count, thousands white blood cells counts, 10,000 of which were eosinophils. Neutrophilia, high liver enzymes, both the ALT and the alkaline phosphatase. But I remind you that this was a very young dog back then. Mesenteric lymphadenopathy, enlarged peripheral lymph nodes as well, hepatomegaly and splenomegaly. And this is back then the kind of diarrhea that this dog exhibited. If you have any questions or if you want to discuss anything about the case, let's go, step by step together as well. So as you see, this was the gastroscopy that we performed back in 2020. Okay, so back then we had an esophagitis stage 2 in the Savary-Miller classification. I'm going to start using from our next cases the Los Angeles classification system because most in human medicine, it's more consistent. So we had, you see here the ulcerations and the erosions in the lower esophagus, proximal to the lower esophageal sphincter. We had mucosal hyperemia and edema. You see the ulceration. We have a lot of retention in the stomach, of food in the stomach. This dog was fasted more than 16 hours, and yet there is food in the stomach retained. We had thickened rugoid folds, erosions, ulcerations, as I said, gastric hypomotility, and it was really, really nasty, as you see the ulcerations. Active, not bleeding, but active, very fresh, not healed. I can't even imagine. This dog should be really in great pain. So we took some biopsies. And let's see more of our clinical history. As I told you, in order to exclude the hypereosinophilic syndrome, we took some bone marrow aspirates. We had liver and spleen ultrasound-guided FNAs, which showed that we only had vacuolar hepatopathy and normal spleen. And in the bone marrow, we did have an eosinophilic hyperplasia with left shift and a small number of immature eosinophils. And for the diagnosis of eosinophilic anemia, more than 5%. We have to have more than 5% of blast cells in the bone marrow, which we didn't. This was excluded as well, but you definitely have to do the whole procedure when you see, especially this breed, having eosinophilic infiltration predominantly in the gastrointestinal tract lumen. And of course, we went on more. You can see the rugae folds that are thickened and the gastric wall, which is thickened as well in the X-ray. The fecal flotation and the direct smears were negative, so we did fecal parasitology exams. We also did a dirofilaria test due to the eosinophils, the high peripheral eosinophilic count, and because this dog was living in an endemic region for dirofilaria as well. The ACTH test negative. Of course, we have to exclude all extraintestinal causes of this severe gastric ulceration and vomiting, prolonged vomiting. The dynamic bile acid test was unremarkable because we had increased liver enzymes. So we exclude step by step all the causes of extraintestinal diseases. And we had also a plain lateral radiograph in order to exclude mostly the eosinophilic bronchopneumonopathy, which could be asymptomatic. Sometimes dogs are coughing and the owners are thinking that their dogs are vomiting because after the coughing comes the vomiting sometimes. So please take a very good clinical history. And when they say that my dog is coughing, ask them, does the cough precede the vomiting or the vomiting precedes the cough, so that you can have an overall idea of what kind of a disease it is. Okay, so this was pretty much all the workup that we have done back then. And of course, we have treated the eosinophilic gastroenteritis with prednisolone, starting at 1 mg per kilo every 12 hours, and tapering the dosage by 25% every 3 weeks. And when we reached the 25% of the original dosage, we extended it for 4 more weeks before discontinuation. Okay, lansoprazole, sulfate suspension due to the ulceration, and ondansetron in order to cease the vomiting episodes. And we have put this dog in a hypoallergenic diet. So the outcome was very, very good. We saw an improvement in the appetite gradually over the next 2 weeks. Weight gain, the dog was bright and alert, playing. The appetite was restored. The eosinophilic count was back to normal after 2 months. So the dog stopped vomiting and he was free of symptoms without any corticosteroids for 2 years. And what happened recently? So recently we had a recurrence. So we had chronic intermittent vomiting again over the last 2 months. And the frequency started gradually increasing, the frequency of the vomiting episodes. We had anorexia and weight loss, and a lack of response to antiemetic agents and to motility modifying agents. So this time, we had a very, very intense abdominal pain in abdominal palpation, hypersalivation, dehydration. We have a deep pyoderma at the base of the tail, tachycardia, and a body condition score. The dog has lost weight of 2.5 out of 5. And the ideal is around 3. So we always, as we said, create a problem list. It's a chronic projectile vomiting. The problems that we have to deal in this case, anorexia, weight loss, and the pyoderma. And as we have already said, we have to exclude always the extraintestinal diseases in order to proceed into investigating the gastrointestinal diseases. And the extra gastrointestinal diseases could be intra-abdominal systemic diseases like liver disease or kidney disease, drugs or toxins, mastocytosis. Please beware of dogs that are admitted with lumps and bumps. Stick a needle and maybe it's mastocytosis, okay? And it could be generalized, could be systemic mastocytosis as well. Neurological causes, infectious diseases and metabolic endocrine. We have already excluded Addison's disease from this dog. And these are the extra GI that I have talked to you about. And let's go through a bit the gastrointestinal causes. The gastrointestinal causes could be located to the esophagus, to the stomach, to the small intestine, or the large intestine. So every time a dog comes vomiting, we have a lot of, and we can see that in cats that come with urethral obstruction, for example. And the first sign that they exhibit is depression and vomiting. And people are looking, into the gastrointestinal tract, whereas the problem is in the bladder. So we definitely have to exclude and locate where the problem is according to the symptoms in the clinical presentation So in the esophagus, it could be due to hiatal hernia, to GERD disease, in the stomach to chronic infiltrating gastritis, delayed gastric emptying attributed to mechanical functional obstruction. In the small intestine, infiltrative disease, neoplastic diseases, fungal diseases, foreign bodies and parasites, and the large intestine, chronic colitis and constipation that can cause vomiting. And let's go to this recurrence episodes test results. So the hematology and biochemistry results revealed mild non-regenerative anemia, mild leukocytosis. It was not like the first admittance. Mild eosinophilia. This time we didn't have pronounced eosinophilia, okay? And we had hypochloremia, hypokalemia, and metabolic alkalosis, and this rings 1,000 bells when you have hypochloremia, hypokalemia, and metabolic alkalosis. This by itself means that we have an obstruction in the pylorus. Okay, the ACTH test, again, normal. We also tested this dog because it had an increased alkaline phosphatase without an increased cholesterol, though, for hypothyroidism in order to exclude the fact that this dog might be hypothyroid, and this could be maybe a clinical presentation of hypothyroidism, the hypomotility disorder. And we also check for pancreatitis because pancreatitis is very well known and established to cause gastric hypomotility. So the urine-specific gravity was 1021, which was a bit low. It was an inactive sediment. We had paradoxical aciduria, and for those of you who attended last time, know now that metabolic alkalosis and paradoxical aciduria are combined as manifestations of pyloric obstruction, and the urine culture was negative. So in pyloric stenosis, what we have is this triplet, as I told you before, and you can have a very good diagnosis with only your electrolytes and your blood gas analysis. Okay, so we have hypochloremia, hypokalemia, and metabolic alkalosis. And we also have paradoxical aciduria because the sodium is reabsorbed by the kidneys, but the potassium is lost through the renin-angiotensin mechanism. So we have an increased excretion of hydrochloride. And when the chloride is reduced, then we have bicarbonate reabsorption through the kidneys that is increased. And this explains the aciduria. And what about the imaging? The abdominal ultrasound findings. In this animal, actually, it was unremarkable. We did not have mesenteric lymphadenopathy. We only had gastric hypomotility, and with the ultrasound, it's a bit difficult. I don't know for those of you who are more competent with the ultrasound. For me, it's very difficult to assess gastric motility using the ultrasound and measuring the gastric contractions. Maybe for an experienced radiologist, this could be very, very easy, but for me, it's very difficult. So the only thing that my radiologist consulted with me was that there was a gastric hypomotility, and we did an upper GI barium contrast study. And you see that this is in 0 time, and you can see that in 0 time, we have a retention of very, very little barium in the esophagus, which is, if it stays there, could be a problem, but it seems that later on, it went away. But it's actually very indicative of a malfunction, of a hypomotility of the esophagus as well. What we're looking for is the string sign or the big sign, which I'm going to show you in the next case, which is very, very obvious. So we took a series of radiographs in 30 minutes, 1 hour, 3 hours, 5 hours, 7 hours, 10 hours. Always don't constrict yourself in lateral position, but please also take in DV position radiographs, because this will help you see the antrum better. And also, you may be able to see the big sign, the string sign. And this was 24 hours later. So in 24 hours later, we didn't have any content in the stomach, but in 10 hours, we still had content in the stomach, which is very, very suggestive of hypomotility. It's not suggestive, it's actually confirming of hypomotility. And our second gastroscopy in this case was on the 23 of January, 2023. So 3 years later after the first gastroscopy with the ulcerations. And let's see what we had. So now we had functional megaesophagus. It's not a megaesophagus per se. It's actually an esophageal hypomotility disorder. And it's probably due to the gastroesophageal reflux disease and the esophagitis that this dog experienced due to the prolonged vomiting episodes. Okay. Retention of foamy material in the esophageal lumen. The esophagus here seems quite good, but very, very flaccid. Let's go and watch a bit the cardia. Always use your hemoglobin enhancer in order to, that the Aohua scopes have, in order to detect better the esophagitis regions. And I have to remind you that this dog, maybe you do not see active esophagitis right now in this dog, but this dog was on, again, on antacids, on lansoprazole, on peptonorm, sulcrafate, and this is why the esophagitis has healed, yet the hypomotility was not restored. So this was after the attempts of the referring vet to restore the esophagitis and after discussions that we had. Okay, this is why you do not see an active esophagitis right now. And let's go and have a look at the stomach and the fundus. First, you see that we have retention of significant amount of gastric fluid and food, and that was almost more than 12 to 16 hours. You see that the dry food has not been digested. Okay, we have a thickening of the rugoid fold, and we have patchy gastritis, lesions like plaques and some ulcerations, erosions, and very, very superficial ulcerations. Okay. If you have any questions on those, or if you want to discuss anything on the case, feel free to comment on the chat box. And then Let's go to the antrum and the pyloric region to see what's going on. So we had the thickening of the mucosa in the antrum and the pylorus. This doesn't look like a very, very, for Rottweiler, a very, very, let me say that, representative pylorus, okay? And the passage from the pylorus to the duodenum was extremely difficult. And this was a dog of 50 kilos, and I used the 8mm scope, and I normally pass the 8mm scope in cats. So you can imagine that having it to be difficult, there should be a pyloric narrowing. But you do not see the representative picture image of the overfolded pylorus that we see in hypertrophic pilorogastropathy. You see, this is not an overfolded pylorus. And let's see the duodenum. In the small intestine, we did have increased friability, increased granularity, diffuse edema and erosions. You see that this is not a very healthy small intestine, duodenum. Okay, but the peristalsis was normal. We have some lacteals up here, these white spots that were full, dilated. This is not a mass lesion. This is from scooping from our scope. So please beware of your autotraumatic lesions, the lesions that you cause, that you might cause with your scope. Okay. We're trying to figure out what this was, but this was tissue that we have actually, when we were inserting the scope, we have scooped mucosa. Okay. And let's see the histopathology. So the microscopic decision in the small intestine, we had chronic moderate, predominantly plasmacytic enteritis, which plasmacytic means chronicity, but there were no eosinophils this time, okay? And in the stomach, there was acquired chronic hypertrophic pyloric gastropathy due to chronic mixed infiltrative gastritis. So here we did have lymphoplasmacytes and eosinophils. And we had fibrosis. And the syndrome, we have talked about it last time, the chronic hypertrophic pyloric gastropathy. For those of you who did not attend the first webinar, could be congenital in some breeds like the Boston Terriers, some brachycephalic breeds, the bulldogs, the boxers, or other small breeds, breed dogs, and in Siamese cats. Could be also acquired in brachycephalic or other small breeds. And it could be caused in any breed due to gastritis, due to chronic inflammation, or due to chronic gastric ulcers. 3 types. Type 1, the primarily circular muscle hypertrophy. In type 2, we have a combination of muscular hypertrophy and mucosal hyperplasia. And in type 3, we have primarily mucosal hyperplasia. And the cause is increased gastrin concentrations that cause changes in the neural plexus of the stomach that leads to chronic antral distension. What was our therapeutic plan in this dog? So we definitely had to maintain our patient and to restore the fluid and the electrolytes and ameliorate the electrolyte disturbances, to restore the gastric mucosal barrier with sucralfate and omeprazole or lansoprazole, PPI inhibitors, and use antiemetics in order to cease the intractable vomiting, like maropitant, ondansetron. If the albumins are really low, you cannot use maropitant, but you can use a combination of ondansetron and metoclopramide, for example. Prokinetic agent, because there was a very, very severe gastric hypomotility, and we use cisapride in this case, low-fat diet, so that it will definitely clear out more quickly from the GI tract. And we also use surgical management. The surgical management, these are the three most popular techniques. In this patient, we actually did UI piloroplasty. Okay, and when you do that, always send the excised full tissue, a full thickness biopsy from the pyloric region, from the tissue that you excised for biopsy. And something that was not diagnosed in endoscopic biopsies was that we had moderate chronic lymphoplasmacytic and eosinophilic gastritis. So in our endoscopic biopsies, if you remember, we only had lymphoplasmacytic or only plasmacytic gastritis, but the true infiltration was lymphoplasmacytic and eosinophilic gastritis with muscular hypertrophy. So always send your excised tissue, even if you know the disease, for biopsy. Any questions on this first case about our management? Any disagreements? Any other proposals? Please feel free to chat, and we can discuss about your questions or your comments. And let's go to this second one. This is Lori. This is a very, very dear. I had this dog since she was a puppy, actually. A very dear dog, very, very good temperament. So this was a boxer, 2 years old, female. So Lori was presented with chronic intermittent vomiting for 2 months duration. And a poor response to common antiemetic treatment. And during the last week, this has progressed over to projectile vomiting, partially digested food after a lot of hours, many hours after the meal, every day. The body condition score was fairly good, 4 out of 5. And there was also generalized pruritus. So she was scratching her eyes, she was scratching her ears, she was licking her abdomen, she was licking her paws. So we have to really, really take a good clinical history up on that. She had chronic otitis externa, acrylic dermatitis, abdominal palpation elicited pain in the cranial abdomen. We had very mild dehydration, and the respiratory rate was mildly increased, but it was summertime, and this is a brachycephalic dog, so we didn't, made much out of it. And the biochemistry results, mild relative polycythemia due to dehydration, and increased total proteins, probably due to dehydration, hypochloremia, hypokalemia, and metabolic alkalosis. So we already know what she has. We already know that there is some kind of an obstruction in the pyloric region. The ACTH stimulation, normal, and the thyroid profile, and I want to comment on that because I had recently another case with megaesophagus. So the T4, the free T4, and the antibodies were normal, yet the TSH was double-fold, slightly increased. So what do you do in these cases? When you have a free T4, that's normal, but you have an increased TSH, please send something in the chat. What would you do in your patients if there is a percentage of dogs, for example, that have low T4, low free T4, and normal TSH, and yet they have secondary hypothyroidism. But what about these dogs that have normal T4, normal free T4, and they have an increased TSH? What do you think in these cases? Is this dog hypothyroid? Would you give T4 or not? What would you do? Don't be scared. We're just, to answer, because we're just discussing. Because this was my initial, my initial wondering as well. What will I do? Will I try T4 in an animal that has an increased TSH or not? And the pancreatic profile was normal. So this is what the books say, that when the TSH is high, then this is consistent with hypothyroidism, but you definitely have to have a low free T4. And when you have a normal free T4, then you definitely have to consider other causes of the patients, for the patient signs. And this is actually what Cornell has published. So when I have a normal T4 and a normal free T4, I would evaluate in a month. Yes, thank you, Nadzena. That's a good answer. Always reevaluate. If you're not happy with your results, and that's a very, very good answer. I really like that. If you're not happy with the results, you are the doctors. Use your intuition, and don't, medicine is not about metrics. Medicine is about intuition, is about combining clinical signs, it's about combining the data that you have from your clinical history. Definitely re-examine. But most of the times when you have a normal T4 and a normal free T4, you do not care about an increased TSH. So you see that with normal or high TSH, normal T4, normal free T4, and even if you have a low T3, your dog is euthyroid. If you have a normal T4, a low free T4, and a normal or high, this is not diagnostic for hypothyroidism. Okay. So if you have, in general, I want you to keep in mind that if you have an increased TSH, this could be from recovering from a chronic illness effect. Okay. So we will not give Lori T4 in this case. We would either, as Nadina has said, re-examine. Nadezhda, I hope that I'm pronouncing your name correctly. We will either re-examine, or we will exclude hypothyroidism if I don't have any other biochemistry, that's supportive of that. And always perform urinalysis. Always perform urinalysis. We have hyperstenuria, proteinuria +1, but with this specific gravity, we do not care about +1. Paradoxal aciduria and an inactive sediment. So we are now certain that there's something wrong with this dog's pyloric region. Okay. And let's go to the barium contrast studies again. And in this case, I'm going to show you the string sign. So this is in 0 hours, 30 minutes, in 1 hour, still the food in the stomach. In 3 hours, you can see this small beam of contrast medium, which is the string sign, that actually, this is how stenotic her pylorus was. Okay, I think this is the only case. I only had 2 cases in my life that I could not tangle the pylorus. This was one of the cases that I could not tangle the pylorus. This is how narrow the pylorus was. And this is what the amount of food that was passing from the stomach to the duodenum through this tiny hole. Okay. In 12 hours, we still, of course, had a large amount of food in the stomach. And let's see her gastroscopy. Okay. So now we're in J maneuver. We see that I have a lot of foamy material. Not very pronounced, lesions in the stomach. Some very, very small ulcerations, but you're going to see the lesions. That this is the incisura angularis. So the fundus and the body had very, very small dotted ulcerations, but not, something very, very pronounced. But have a look at the pyloric region. It's like the pyloric region has chicken pox. Dotted everywhere. This is actually what we see in hypersensitive dogs from food allergies, for example. This is what we see in food allergies. This is how they are. This dotted appearance of the follicles. Okay, these are inflamed gastric follicles. Okay. Look how amazing the picture is, and it's very, very representative. And you see that the pylorus is not overfolded again. So please do not have this mindset about pyloric hypertrophic pyloropathy that you definitely have to see an overfolded pylorus. There were not all the cases. It's 50-50. You might not see this overfolded pylorus, yet you might have pyloric fibrosis. Okay. And we had these pathology results. So moderate infiltration by lymphoplasmacytic, by lymphocytes, eosinophils, and plasmacytes. And the B is from full thickness biopsies that actually reveal extensive fibrosis. In the endoscopic biopsies, we did not diagnose fibrosis. Okay, so this is why I always want you to send the full thickness biopsies. And in this case, what we did was Heineken-Mikulicz, not the YU, piloroplasty, and of course we gave some antibiotics postoperatively, low-fat diet, metoclopramide as prokinetics for 2 weeks. And just to make sure that everyone knows what the Heineken-Mikulicz is, you incise the pylorus longitudinally, and then the incision is closed transversely. So this actually enlarges the pyloric, the pylorus. Okay. What are the pitfalls? We did a lot of mistakes in this case, actually, and I want to share those with you because I don't want you to make the mistakes, and I never have done the same mistake. I just saw this was an old case from 2008. So I did not take under consideration the pruritus. The owner was complaining that the dog was itching. And just because it was, springtime, summertime, that Lori has exhibited the signs, I was pretty much, convinced that this was environmental allergies. Maybe it was, maybe it wasn't, but it was not evaluated. And that was a mistake. Because could it have been the primary cause of vomiting, for example, an undiagnosed food allergy? So an exclusion diet should have been used in the beginning of the vomiting episodes, and even more so, even earlier, when the owner was actually complaining about itching and having recurrent otitis episodes. And the other mistake that we did is that when our surgeon opened the, corrected did the Heineken-Mikulicz, corrected the pylorus, performed the pyloroplasty, I did not request, this was not the surgeon's mistake, it was my mistake. I did not request for biopsies to be taken from the small intestine. So I don't know if this dog had an infiltration in the small intestine as well. So just, when you're done with a case, always retroflect and always see what you did wrong, in order not to do it in your next case. Okay, Tom, the question is, what is your cutoff period when you expect the barium to be passed from the stomach and you start to worry about the abnormal passage? A normal stomach is emptied in about 4 hours. It depends. Is it kibbles? Is it dry stomach more than 6 hours, then this is hypomotility disorder, definitely. 4 to 6 hours is tolerated because some dogs, for example, have are chewing their toy bones, and these are, or they have a dry food that's high in fat content, and this makes it harder for the stomach to be emptied. But in general, this has to be, you cannot accept more than 6 hours food in the stomach. Okay. Any other questions on that? And I'm going to go to Byron. And we're going to talk a bit about bilious syndrome. I'm certain that you're all aware of, thank you, Tom. I'm certain that you're all aware of these clients, of pet parents that come to your practice really, really angry and agitated because their dog is vomiting these, greenish stains on the carpets every morning, every single morning. So this is how this client came, this patient came in the practice, in the clinic. This was a Maltese dog, 2 years old, male intact. And the primary complaint was that this dog had exhibited a chronic intermittent vomiting only in the morning. And it was only bile content. It was not even gastric content. It was never, or hardly ever was it yellow. It was, most of the times, was greenish. And at times in the morning, this dog exhibited ptyalism, nausea, and anorexia. The body condition score was normal. And other than that, the dog did not exhibit any pain, no diarrheas. The appetite was normal, apart from this morning nausea. Okay, and in the clinical history, there was this tendency of the owner to be a late, how can I say that? A late sleeper. So he was not a morning person, the owner. The owner was waking up around 12 or 1 o'clock p.m. I don't know where this person worked. So the dog never had a morning meal. And the last meal that he was receiving was around 8 to 9 p.m. So the stomach was more than 12 hours empty during the night. Okay. Let's see. The clinical examination, abdominal palpation elicited pain, but these small breed dogs are a bit agitated when you palpate the abdomen, so you never know if it's true pain or if it is just, they don't want to be touched. The hematology revealed mildly increased monocytes, pretty much normal. It was normal. The biochemistry, mildly elevated ALT, but mind you, this is a Maltese dogs, and Maltese dogs very, very frequently have an elevated ALT due to microvascular dysplasia, for example. Hypochloremia. The urinalysis unremarkable, the abdominal ultrasound unremarkable, no mesenteric lymphadenopathy, no nothing. The baseline cortisol normal, but beware when the baseline cortisol is in the gray zone, because this could be a typical Addison. It was not the case here, but beware of that. And the bile acid test was normal. We always, do the bile acid tests when we have an elevated ALT. And what about the upper GI endoscopy? In the upper GI endoscopy, we had duodenal-gastric reflux disease, diffuse gastric hyperemia and edema. And we, of course, had a gastric hypomotility. Every time that you have duodenal-gastric disease, you definitely have gastric hypomotility. And let's see what happened here. Okay, you will see that the content in the pylorus is going in, but it's retained all the time there in the pylorus without being proceeded into the duodenum. And at some point, I will flush because I really wanted, to get all this food out of the way so that I can see what's going on. And once I flush, you will see, now I'm flushing, you will see that this will be preceded into the duodenum, but the duodenum will reflex it back into the stomach. Oops, you see, it went out again. So this goes like in and out again. Okay. And this is what duodenal-gastric reflex disease looks like. And what we did is that we gave lansoprazole and cisapride, prokinetic agent, low protein diet or novel protein diet in these animals. And what you have to do is actually, this is the key to the solution, just split the meals to 3 to 4 times per day, with the first very early in the morning and the last very late at night, so that the stomach, is covered throughout the day and is not left empty for long periods. I'm certain that you do have these kind of cases in your clinics. And this is what functional obstruction is, which is not, as I told you, a true obstruction. It's functional. It's hypomotility due to functional factors. And it could be due to primary gastrointestinal disease. It could be due to extraintestinal causes. All these causes might cause hypomotility, like electrolyte disturbances, acidosis, drugs. We have critically ill patients. All our ICU patients are patients that exhibit gastric hypomotility. In remic patients, liver failure patients, all diseases that can cause abdominal pain, like peritonitis, for example, can cause hypomotility as a secondary effect. Okay. And what about the bilious syndrome? It has been recognized in humans, in dogs, and in cats. It's normal in young puppies and in kittens due to reduced endogastric pressure and reduced pyloric contraction. And the key is that the pathogenesis is that the endogastric pressure is bigger than the duodenum pressure. So how do we assess gastric motility? There was a big debate, about how to assess gastric motility. Can we do it with plain radiographs? Without a contrast medium, I think it's practically impossible. With barium contrast study, yes. And as I told you, one of our colleagues asked priorly, the normal gastric emptying hours, 6 to 8 hours. I say 4 to 6, even in dogs. If they stay more than 6 hours, then I consider that something is wrong. Fluoroscopy, gastric emptying ultrasonography for the most competent of you. And the smart pill. We have now the smart pill. I'm going to show you what the smart pill is. I've used it once or twice. And TC radioscintigraphy. This is not, a common modality. So these are the BIPs, the barium impregnated polyethylene spheres. And there is a designed transit time for these spheres that you can find either in the manufacturer or in papers. I have used them, yes, but I'm more familiar with the barium contrast study. So for me, it's much easier. The only thing is that they can detect other things as well. And this is from my CR. This was a dog with generalized, actually, hypomotility in the esophageal area as well, and gastroesophageal reflux disease. And this is how we do the study. This was not a diverticulum. So you see that the first swallow goes fine, but the second swallow, you will see now that we are approaching the stomach. it gets a lot of effort to go through the esophagus into the stomach, and there is this U shape. So it all stays to the proximal to the lower esophageal sphincter. A big amount of food that stays here in this dog. This is the stomach on the right. And once the food goes in, then it goes out again. So we have a gastroesophageal reflux disease. And the same thing could be assessed in the pyloric region. It's more easy to assess the gastroesophageal reflux rather than the duodeноgastric reflux with fluoroscopy. But this is another modality that we use for to assess gastrointestinal motility. And what about treatment? I know that most of you use metoclopramide. The prokinetic, though effect of metoclopramide, evidence-based, was not proved. Only for the liquid phase, it was proved in dogs, not for the dry food, for example, or the canned food. Metoclopramide targets in the lower esophageal sphincter, the stomach, the small intestine, and the chemoreceptor trigger zone. Domperidone as well is another prokinetic agent. Cisapride, I don't know if you are, if cisapride is available in your region or not. It's an amazing prokinetic agent, both to the small intestine, for the large intestine, to the lower esophageal sphincters, for dogs with a megaesophagus, with hypomotility disorders. Masapride mostly for the stomach, and prucalopride. I've used prucalopride in large breed dogs for the large intestine with constipation, for example. The Gastrode, unfortunately, here in Greece, we do not have the Gastrode, but it's an amazing prokinetic agent. Erythromycin, very not potent, very, very mild in its action. And the same goes with ranitidine and nizatidine, which we thought that they had a prokinetic effect, but to which extent we actually do not know. So the future for the prokinetic therapy is the 5-HT4 receptor and agonists, which were the serotonin agonists, but cisapride, for example, was banished from the human drugs because it could cause delayed rectifier potassium channel, and it caused problems, heart problems in humans. Unfortunately, it delayed cardiac repolarization, which was not an effect in dogs. Another one was botulinum toxin A as a treatment for delayed gastric emptying in a dog that was refractory to prokinetic therapy. And the big newcomer, especially not for gastric, but for esophageal dysmotility or hypomotility, is sildenafil. And it has been proven that for canine megaesophagus, it's really a very good choice to go for. But we need more studies and we need more patients to try it on in order to see where we're going from there. And even though it has very good effect on esophageal hypomotility, doesn't seem to have an effect on gastric hypomotility disorders, unfortunately. And the last one is a case. Do you have any experience with the medications? What medications do you use mostly? Please write in the chat box so that we can have, I can have a look at what you're using. And if you have heard about sildenafil, and there's another one for the esophagus, bethanechol, which is actually Kirk, in the books of Kirk, it has been mentioned that bethanechol from 1973, it has been used for esophageal hypomotility with good effects, but I've never used bethanechol because we don't have it in Greece. Please write in the chat box what are the prokinetics that you're using. most of the times in your hypomotility patients. Okay, and we're going to have the last one. This is Persa, an American Staffordshire, 6 years old, female, neutered. This was fully vaccinated and dewormed, 75% indoor dog, no other cat or dog in the household. And this dog has been regurgitating and vomiting 3 days prior admission. The clinical signs were anorexia, intractable vomiting. The patient could not stop vomiting. Gastric fluids, undigested food, partially digested food, with no correlation to meals, salivation and ptyalism, taking very, very frequently Prayer's position. And the referring vet has used ranitidine, maropitant, amoxicillin, clavulanic acid, I do not know why, and B12. But over the last 2 weeks, the dog was deteriorating, so it was referred to us. And the temperature was normal, and the respiratory rate was normal. The BPM slightly increased. The auscultation normal. The abdominal palpation revealed thickened intestinal loops and pain in the cranial abdomen. The digital palpation revealed no feces, and please always do a digital palpation. You might find the root of the problem. Tacky mucous membranes and a dehydration of 10%. The hematocrit was elevated due to dehydration. We had a neutrophilic leukocytosis. Something is wrong. Some kind of an inflammation is there. There was a regenerative left shift. We had increased band neutrophils, monocytosis and eosinophilia. The BUN was elevated because the dog was dehydrated, and the total proteins as well for this reason. And we had hypokalemia, hyponatremia, and hypochloremia. The rest of the parameters were normal. And this was Persa's lateral abdominal radiograph. And you can see that there is something wrong in this abdomen without being able to define it. This is a blurry picture, of the stomach and the intestine. It's not very obvious, the margins of the organs. There's something wrong. And of course, what we needed to do was to support the patient with fluids, nutritional. I'm going to show you the endoscopy that we did. Replace the electrolytes, and if we detect any foreign bodies, perform early and appropriate surgery. Let's see the scoping. You can see the radiance of the esophagitis. This is severe. This is due to severe vomiting. You can see it perimetrically. So this is esophagitis stage 2. And once you can also try the hemoglobin enhancer here, because it will make them more, it will make the lesions more prominent. There already are in this patient. And you see that the esophagitis has reached, it's not only located proximally to the lower esophageal sphincter, and here we have the HB on, and you see how prominent the lesions get to be. This is one of Aohua's best options to detect the ulcerations and the erosions and the inflamed areas. So you see that the esophagitis is extending up to the pharynx. This is how severely this dog vomited. And if we go into the stomach, you can see that there is gastric distension. When you see this kind of gastric content and retention of this amount of fluid, then you only think about obstruction or pyloric stenosis. Is it a foreign body in the pyloric region? Is it stenosis of the pylorus? Is it, intestinal obstructions? These are the things that you are, because this is severe hypomotility. The content cannot be promoted into the intestine. So it was stage 3 esophagitis due to the Savory-Miller classification, and according to the Los Angeles classification, which the human doctors like more, and I will adapt, it was grade C, actually. And let's see what happened. I was able to pass the pylorus, so there was not, what we did is that we emptied the stomach with a tube, and then I tangled the pylorus. I inspected the pyloric region, and I saw that there was no foreign body, no stenosis. So we got into the small intestine. And I was, at this point, I was definite that there was some kind of an obstruction. And what made it very, very clear was the fact that I stumbled on the foreign body. Another thing that you can find when you have an intestinal obstruction in the proximal duodenum is that you might have fluid coming over onto you, okay, retrospectively. Even if you don't see the foreign body, if you see fluid going backwards towards the pyloric region, then this is very indicative of a foreign body. So that was the foreign body. These are the lesions that I've told you. This was the foreign body, intestinal foreign body, and we have gastric, and we had delayed gastric emptying due to this mechanical intestinal obstruction. So this was pretty much everything, and I've covered all the fields of mechanical and functional pyloric obstruction, the gastric, the assessment of gastric hypomotility, and also the medications. They will be available with the dosages through a link to you. And I'm more than happy to discuss cases with you and also to answer your questions and everything. Thank you very much, Abdullah, for being here. Thank you very much. I will be in 2 weeks from now, beginning of March, I will be in Singapore for a 4 days endoscopy workshop. We're going to cover all the systems. We're going to cover upper and lower GI. We're going to cover respiratory, rhinoscopy, cystoscopy. We're going to do pretty much everything in Singapore. Stay tuned and look at Aohua's announcements about those. And then I will be in Dubai and then in Saudi Arabia. So for those of you who would like to attend, stay tuned for more information with Aohua. And we will stay in touch for our next webinar. If you have any questions, I'll be more than happy to answer, even in my email.
Thank you. Yeah, we'll wait for some questions now.
I will come in Dubai because I'm invited to the World Police Summit, 5 to 7 of March, Abdullah. And I will talk about exocrine pancreatic insufficiency, IBD, and antibiotic responsive diarrhea in police German Shepherd dogs. So I'll be happy to see all my friends in Dubai at the World Police Summit. And Jason, I have to confess that we will have a very, very interesting case about the one that we will announce now. I will send it to you tomorrow or the day after tomorrow. And it's going to be about a tiger. And
wow.
yes, and it's going to be about asthma-like eosinophilic bronchopneumonopathy in a leopard, in a Persian leopard, actually. So it's going to be very interesting. because we
Wow.
did that, and
So
very, very happy
exciting.
that my colleagues will have the chance to see that as well.
Cool. How about the last case? Is that okay? I've sent you the email.
Yes, it's
Okay,
okay.
so okay, so
Yes.
I will release it. Okay,
Yes.
cool. Yeah, for the attendees, if you still have some questions, please feel free to ask. The last chance.
Thank you very much, everyone. And I really wish you a very nice day in your clinics, in your practices. Please email me for any problem you might have, in terms of gastroenterology or endoscopy and endoscopic procedures. And I will be more than happy to discuss the cases with you. And I had one friend that actually asked, Panayoti, I will answer to you. I've seen your case, and we will talk. After we finish the webinar, we will talk about it. Thanks a lot. Thanks a lot, everyone.
Also, thank you for Dr. Vasiliki's brilliant presentation. The three cases is very incredible. Okay, thank you.
Thank you very much. Thank you.
Okay, so see
Bye,
you next
everyone.
time. Bye.